Hello, welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nate Pennell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. Now, hopefully all of you out there are aware by now that the September issue of the JOP was devoted to a special series of papers on palliative care and oncology. Over the last decade, we've really seen a growing recognition that palliative care is every bit as important in the care of cancer patients as treatments such as chemotherapy and radiation. And for me, this really goes back to Jennifer Temmel's New England Journal paper looking at integrative palliative care in lung cancer patients. But there's still a fairly new field out there in terms of research and our understanding of what the role is for palliative care in care of our patients with cancer. So joining me today is Dr. Tony Bach to discuss his editorial in this special issue of the JOP titled, "What Enables Oncologists to Discuss Goals of Care with Their Patients? Practical Ways Towards a Culture of Kindness, Transparency, and Responsibility." Dr. Bach is a professor of oncology and the co-director of the Center of Excellence in Palliative Care at the University of Washington School of Medicine. He specializes in treating gastrointestinal cancers and is also an expert in communications between physicians and patients. Tony, welcome back to the JOP podcast.
Thanks. It's great to be here.
We first did a podcast with Tony back in 2015 when we talked about your paper on the resident experience on an inpatient oncology ward, which is still one of my favorite papers in the JOP, and I talk about it every time I'm on service with my residents.
Thank you.
So tell me a little bit about this issue of the JOP, the special issue on palliative care.
Yeah, well, I think that the integration of palliative care into routine oncology care, early integration, as Jennifer Temmell would call it, has really reached beyond a tipping point and a place where it's really going into the mainstream. I talked in the editorial about how if you look at this as a diffusion of innovation, that's something that the sociologists use to describe how new practices come into being and are adopted. If you look at this as a diffusion of innovation, there were the very early adopters like Jennifer and her group that kind of set a standard for all the rest of us. And now what we're doing is taking that practice that was defined in a randomized trial in a very specific population, and really it's going mainstream. And so the question now is, what do we need to do to take it mainstream? And that's why I brought up the issue of having oncologists talk about goals of care, starting early in the illness, revisiting them as the illness gets more serious, and then coming to some real decisions at those different points during the illness trajectory. Because I think we now need to think about goals of care as not just something you do right before a hospice referral. Goals of care are something that we should all be doing at these turning points in illnesses.
I think it's interesting, this concept of the early adopters and people who really were excited about this and rolled it out, and versus the late adopters now are who are more skeptical of how they can take part in this. And I also thought it was really interesting how the concept of having access to palliative care kind of allows oncologists to pass the buck of these discussions on to the palliative care experts.
Yeah, one of the papers in this issue of the Journal of Oncology Practice is by Calabrese and Case, and they describe a pattern where they called it good cop, bad cop, where the oncologist sticks to the good cop role, meaning, I'm going to keep giving you hope and only talk about new possible treatments or clinical trials. And then palliative care takes on this bad cop role, which is, the treatments aren't working very well and you need to make some plans. I think that's kind of a rut that can be seen as an example of what happens when innovation runs into later adopters who are often concerned about taking on new practices until they're really convinced that they're going to work in their exact setting, right? I don't think these are people who are skeptical about science. I think they're people who are thinking, I get that this worked in this, clinical trial in academic medical center in Boston, where they have like unlimited access to palliative care people, and the palliative care people they have are the best in the world. But is it going to work in my place with the palliative care people I have? And I think there's some reason to be understanding of that skepticism. And yet, the good cop, bad cop scenario, it doesn't help us move forward in terms of trying out new innovations. And even for the late adopters, it actually doesn't help them test out whether the innovation is going to work in their context, because that pattern kind of reinforces the existing too little, too late approach to palliative care. And so I think one of the things I was interested in exposing this pattern of adoption of innovation is to help oncologists see where they might fit in and what might be the next steps that they need to take in their own practices to change what for many of us has been a very long-standing practice, right? I mean, I was taught as a fellow that you don't start talking about hospice until you've totally been convinced that there's no more anti-cancer treatment, right? That's what I learned. It takes a while to unlearn something like that when you've been practicing for a while.
And it's interesting because it hadn't really even occurred to me till I was reading some of this in preparation for the podcast, but we teach our fellows in oncology the importance of palliative care, but we probably don't spend enough time teaching them how to have these conversations.
Yeah, I think that's absolutely right. So, one of the reasons that James Tulsky and Bob Arnold and I started Vital Talk as a nonprofit was to make this kind of training much more widely available, because most people with cancer, they feel like they have a really important relationship with their oncologist. And I think when they hear that things aren't going well in this way from another clinician, I think it's really damaging. I think it really shakes their trust in their oncologist. I think it really undermines a really important relationship, because honestly, the oncologist is the one that they've been relying on to make big decisions, all this time, often for years. And so there are other studies that show that 30% of patients with advanced cancer find out that their situation is something where more anti-cancer treatment isn't going to help. They hear it from a doctor they've never met before, right? And I think what that is telling me is that there is a huge role for oncologists to play in bringing this issue up. And I don't think oncologists necessarily need to do it all, and they don't need to necessarily do the most complicated ones. That is where you really do need your palliative care colleagues, because, for those people, it takes a village. But I think it's really important for oncologists to be involved in the first level of these conversations with all their patients.
No, absolutely. And now, one of the papers that you commented on in your editorial, I think, was perhaps giving a little bit of a hopeful result in terms of oncologists communicating prognosis to their patients.
Yeah.
Can you tell us a little about that one?
Yeah, it's a study conducted by Savendran et al., and there were 208 patients at a community-based cancer institute. And they actually found something a little bit unexpected, that patients with stage 4 metastatic disease were more likely to report their stage accurately than patients with early stage disease. And, this is an institution where palliative care is embedded in the oncology service. And so patients have, I think it sounds like, quite easy access to both oncologists and palliative care clinicians. And, it makes you wonder if this extra attention to patients with metastatic disease actually results in better understanding for them. And I think it's a very intriguing finding.
It sounds like the second paper was really offering some suggestions on doing goals of care discussions. Can you tell us a little bit about that?
Yeah, so I commented on a paper that was written by some people in our group that work with us in Vital Talk about a framework that oncologists can use as a handy way to guide them through a goals of care conversation. So the first author was Childers, and it's the REMAP framework, REMAP, and those initials stand for reframe what's happening, meaning make it clear that the status quo, having one more kind of anti-cancer therapy, isn't working anymore. The E is for expect emotion, because that's upsetting to most patients. And when oncologists provide a moment of empathy, it helps patients process and absorb information. Then the M is for mapping out patient goals and values so that oncologists can understand what's really important to patients at a difficult time. The A is for aligning with goals, meaning that it's worthwhile to explicitly say, I hear these goals and I am with you on them. Because I think when oncologists jump straight to the plan, which, we're all doers, right? Patients miss what the oncologist is suggesting actually flows from the thing that they talked about, right? And so then proposing a plan is about making a recommendation that's based on the patient's values. And so this little talking map is a handy way to remember what's important when you're doing a goals of care conversation. You don't have to do every step every time, but it's the kind of thing that's a roadmap that will remind you not to miss something important.
Lastly, I like the concept that you have, and this is something obviously that works best if you have a really good dedicated palliative care service with you, but having so-called escape hatch. So you can work to have goals of care discussion with your patient, but if you feel like things are going off the rails, you could say, well, I think we've probably talked a lot about this now, and now I'm going to bring in someone to help with this conversation maybe the next time you come back.
Exactly. My idea with that was to give oncologists a practical sense of when the conversation is complicated enough that it really is worth consultation. This is like when your patient has some kind of crazy infection and you've tried to treat their pneumonia twice and they still have it, and now it's time to call the ID specialist, right? So this is when you call your palliative care colleague. When you feel like you've tried to discuss the situation a couple of times and they still don't get it, when the patient is so emotionally worked up that you're worried that if you say the wrong thing, it's going to be bad for your relationship. And then I think those are times when it makes sense to say, hey, we've done a lot of work today. Let's pick this back up, and I'm going to bring somebody else who works with me a lot on these kinds of things. And so I think that is a totally reasonable thing for an oncologist to do. We should expect ourselves to be able to take care of every kind of psychological and communication issue. There are specialists for that kind of thing. We just need to make sure things get started in the right way and that we point to specialists when we need them.
And this is something we've been doing for a long time, I think, with inpatient family meetings. But I really like the idea of doing this in the outpatient setting on a more routine basis when it's not a crisis.
That's right. And I think, honestly, it could make the lives of a lot of oncologists a lot better. I think there's a lot I hear anecdotally of just a lot of frustration about what happens in clinic. And this is where I think we should make it easier to grab somebody who can help with a tough conversation.
Tony, thanks so much for joining me today to talk about your editorial and the palliative care issue in the JOP.
Thank you.
And I want to also thank our listeners out there who joined us for this podcast. The full text of Dr. Bach's editorial, as well as the palliative care issue, is available at ascopubs.org/journal/JOP in the September 2017 issue. This is Dr. Nate Pennell for the Journal of Oncology Practice signing off. Thanks for listening.